Are we ready to start for a discussion on bone health and menopause? And as a disclaimer, the extreme heat in the women's lounge is not to remind you of hot flashes. It is not a staged event, but I'm certainly feeling it, and I know a lot of you are, so that's the York Club. I don't know if it's humor or not. Well, I know, but I figured it's a precursor. Oh, they're back. Here we go. Anyways, welcome to the Women's Power Circle and another premier event in our calendar to support and celebrate women's health and research at St. Mike's Hospital. My name is Martine Ehrman, and I am the co-chair of the Women's Power Circle alongside with Honourable Nikki Eden. Thank you to everyone who's here in person at the marvelous York Club, who needs a little heat learning. But notwithstanding, I digress, the food will be great. But also to those who are going to join us remotely. International Women's Day is right around the corner on March 8. And at the current rate of progress, it will take until 2158, roughly 5 generations, to reach full gender parity. That's according to the World Economic Forum, and I must disclose quotes. Despite all the gains women have made over decades, we still face many inequalities, including in our health care and in our health outcomes. And the odds are further stacked against women who experience disadvantage due to poverty, racism, homelessness, sexual orientation, disability, intimate partner violence, and other forms of marginalization. Far too long, women's health research has been chronically underfunded. The esteemed journal titled Nature reported recently that just 5% of global R&D was funding to women's health research. That's in 2020. Disparities in research and other inequalities translate into a gender health gap, meaning that women spend more time in their lives in poorer health than men do. The good news, is that we now have data about gender health gap. The knowledge inspires action through conversation, through myth busting, and to the power of philanthropy. Donors can help close the gap by investing in women scientists and underfunded areas of women's health, including health aging and menopause. In Canada alone, more than 10 million women, that's 26% of Canada's population, are under 40. The need for change, they're 40 and older, pardon me. The need for change is greater, so is the opportunity. The Women's Power Circle was established to rally philanthropists in support of women's scientists, women's health research, and women's health care at St. Mike's Hospital. Each year, we hold 3 events like this one, where members gather in nice areas, hear about leading clinicians and researchers at St. Mike's, ask probing questions, and learn. It's also a tremendous opportunity to network and also meet different women. Today's urgent and timely topic is the link between menopause and bone health and the role hormone therapy, HRT, can play in preventing osteoporosis and other health conditions as women age. We have the honor to have Dr. Christine Dersko here today to share her vast knowledge of how hormone influences bone health and what we can do to maintain strong bones and prevent fractures. Hormone therapy is a central topic. It is 2025. And finally, menopause, hormones, and their impact on everyday life are being talked about openly. But there's still so much misinformation and confusion. Dr. Dersko has got decades of clinical experience in research and supporting women's health before and during menopause, including the safe and appropriate use of HRT. She will bring us to speed on the evidence of its use, also what the taboo in the room was for 20 years, and how HRT can help support women's health today. You'll have time to talk and ask questions. After that, we're going to go to a cooler room to have lunch, but we will also be able to ask questions of Dr. Dersko. I will turn to Honourable Nikki Eden to do a formal introduction and be the Q&A. Thank you.
Thank you. She's a great co-chair. Hello, everyone. As Martine mentioned, we have the privilege of co-chairing Women's Power Circle. It is my great pleasure to introduce Dr. Christine Dersko, a strong voice and long-standing advocate for women's health. Among her many credentials, Dr. Dersko is a clinician, academic, researcher, and educator at St. Michael's Hospital and the University of Toronto. Her primary clinical and research interests are in menopause and the perimenopausal transition. Men would understand that, wouldn't they? How many male doctors would understand that, right? Osteoporosis, sexuality, and the gynecological consequences of cancer and strategies for breast cancer reduction. For decades, Dr. Dersko has been an advocate for the safe and appropriate use of hormone therapies to prevent debilitating conditions including osteoporosis as women enter and go through menopause. Dr. Dersko has contributed her expertise to numerous organizations, including the International Menopause Society, the North American Menopause Society, the Osteoporosis Canada, and is a founding member of the Canadian Menopause Society. Please join me in welcoming Dr. Christine Dersko.
Thank you very much. Well, it's a real honor to be here. Thank you. I'll put my water on this side so I know which one is mine. First of all, thank you for that lovely introduction, and thank you for the invitation to come and speak on a topic that's really important. Really important. It's important to me, but it's important generally for us women. And it's important across, okay, something is somehow I'm standing with my mic too close to another mic, but I'll stand somewhere. I'll stand away from there. Well, it's here. Or not, I mean, full disclosure. Yes, it's a real honor to be able to do this. I hope to make this a little bit broad-based so we can talk about things that maybe just in the postmenopausal years. I work in the bone clinic now, but I also have, as Nikki has mentioned, have worked across many ages of patients. As a matter of fact, my first introduction to gynecology was pediatric gynecology. I was the first fellow in pediatric gynecology at Sick Kids with Carol Cowell, who had just come back, and my mentor at St. Mike's, who was an incredible person, Dr. Alan Wolliver, said, "What the hell is pediatric gynecology?" I said, "It's more than just little women. They have their own problems." But then, as I grew older, my kids grew older, my patients grew older, and I went through the time, so I still see some kids, but now no longer. So I say the middle age, and then I got to menopause, and then the osteoporosis. And I'm thinking to myself, oh my gosh, this is a full spectrum of people that I see, and in fact, that's really important because some of the things I want to talk to you about really cover these other areas. I'm an academic, and an expert is somebody who brings slides. So I've got to have slides. I don't need to speak to the slides. They're more for me to illustrate certain things. If you're bored of what I'm saying, well, look at the pictures or just make a face at me, and I'll move along. But I really want to share some information with you. I'm here for you. You can interrupt me anytime if my bosses here tell me if that's okay, and if it's not okay, I guess you can't interrupt me. Then you got to do what they say. I'm the guest. So I want to tell you about this, and again, thanks for the invitation. But estrogen works in lots of places. So we've talked about the fact we're going to talk about bones and muscles, but it acts on the brain, on the heart, the liver, ovaries, vagina, breast, and uterus, and that's important. We're going to do bones, but it's the worry about the breast, right? People say, "Oh my gosh, but the breast cancer." What about the heart? Got to talk about that. And these other things, the brain is something with hormones. Yeah, that's an area of real hot research. So I can just mention some of these things as we move along, but it's really important to know when we talk about whatever we do, either the lack of hormones or getting hormones, it works in all these places. So the first thing is bones. So this is a little cartoon that talks about what happens with your bones. So little kids, when you're a little multicellular organism somewhere back here and you're growing, but then you get born and you start growing. And there are two kinds of cells in the bones, ones that build bone and ones that remove bone. So we always have fresh bone. It's not 80-year-old bones or 50-year-old bones you've got. It's always being renewed. But the bone builders, if they're working at the same rate as the bone removers, you're just renewing bones. If what happens is you're getting more bone building and less removal, you know what happens? You grow taller and taller and taller, and these little kids that start like this, all of a sudden you're looking up at them and say, where did you come from all of a sudden? And that's the growth. You reach this peak bone mass, and then for us women, guys go way up to here. They go higher, they go longer, and they reach a higher bone density, and that's why bone problems are more common in women. So we come along here, and it's fairly stable. Then the bone builders and the bone removers are about working at the same rate, and then something comes along. It's called menopause. And we lose those hormones, and the hormones drop. And as the hormones drop, our bone density drops. Men don't have that. So they're staying up here, coming along. Yeah, they get down a little bit less bone, about this rate, but way, way above the level we're at. And depending on, we women, depending on how quickly we're dropping bone, if we drop too quickly, we get down into the osteoporosis range. If we don't drop as quickly, we do better. If hormones are the cause of the drop here, then if we can do something to slow down that drop or prevent that drop, we've already made a difference. And so somebody who doesn't quite get to a good level, which is one of the reasons we all got to go home and tell our, it's either our kids or our grandkids, make sure you're eating properly, make sure you got enough of that calcium, get those bones built, because if you don't get up to this level, if you never get there, you're going to always be at risk of losing bone and being lower. And you're going to, of course, drop into the osteoporosis range much more quickly. So that's telling our kids, and then maintaining these things. And if you should stop having hormones for some reason too early, you drop that bone very fast, and that's important. So this bone drop happens at a particular point in menopause. It looks like just a little hill. But if you look at that closely, and we've done some of the work on that, the issue is sometimes the amount of bone you lose from here to here, and this is, let me go back just 1 second. So your period, menopause by definition is the last menstrual period. But you never know it's your last until you've gone for a year. If you go 11 months and you have a period, you start counting all over again. So for a year, you don't know that you've had your last period. And then you say, yep, I've had a last period. The loss of bone starts the year before that last menstrual period, and you go down quite a bit, quite quickly. And so if you look, this looks at bone in your spine, and this looks at bone in your hip. And these are important because those are the two areas that we measure when we do bone density. So any of you have had bone densities done, and I'll show you a picture for any of you who haven't and have some concerns about having it done, it's easy. But you start losing. So menopause starts here, you know it's your last period, but you've already had this much loss beforehand, and then you lose this much in that year afterwards. So before you get to the postmenopausal period, you've lost a good 10-15% of your bone, and sometimes more if you're unlucky. You lose it more in your spine, less in your hip, less you lose it. You just lose it at a slower rate at the hip because it's a different kind of bone. We can talk about that some other time. This is Laura. Laura is somebody I discuss when I do my presentation for the students, the residents, on a monthly basis as they rotate through. Laura's lovely. I wish I could have looked like that at her age. I'd love to look that way now too, but that's not going to happen. But she's 23. She's gorgeous. She's tall. She's slim. She's athletic. Gorgeous legs. She's a runner. She has a BMI of 17, and she hasn't had a period for 4 years. And she doesn't want to get fat either, so she's not going to, don't talk to her about stopping running, because that's what she does. And that's what she wants to do. The unfortunate thing is Laura came to us because she got a fracture. She had one of these spiral fractures of her lower leg. And that's frightening, because she didn't do it. It's not that she fell or a truck hit her or anything. It just, the bone cracked, because she is amenorrheic, meaning she doesn't have periods. That bone loss occurred. That means her estrogen was very low. She lost bone. She's stressing it. And on top of it, when she's got this condition where she doesn't want to get her weight up, she's stressed about that too. That means her cortisol levels are high. All these things are bad for bones. So let's keep our girls all looking this gorgeous. I have 3 gorgeous daughters. I have 5 gorgeous granddaughters. The littlest one is only 10 months, but she's going to be gorgeous like the rest of them. We want them healthy. We want them to exercise. We want them to be well. We want them to watch their weights. But we do want them to be eating enough that their periods are there, because that's one of the signs that they've just pushed a little too hard. So we had to treat her, and it's a long time. For those who have done some of the psychology here, better than I know, you know it takes a long time to get these people to get back to normal. Breastfeeding, it's good for you. Mom, what could be better than breastfeeding? I tell all my patients, please breastfeed. It's the best thing you can do for your children. It's the best thing you can do for your own breasts. It's great. And besides these 10, that's the ad from Canada, from Health Canada. But I have, in the last 2 years, I've had 3 patients, 2 lawyers and 1 doctor, who breastfed, but they also forgot perhaps to have enough calcium and genetically were predisposed to having weaker bones. So what happens, and that's not to say you shouldn't breastfeed, do breastfeed. Remember, that takes calcium. When you're pregnant, your body, there's this, what we call a calcium pump. So every bit of calcium you get into your system, you scoot it over to the baby because you got to take care of that baby inside here. But then the baby is born, and the placenta's not there doing this shuttling along of all this calcium. So afterwards, if you're not taking in enough calcium, you're going to be at risk. So one of my patients breastfed for 4 years. We all have our decisions how long we're going to breastfeed, but the other one had only been breastfeeding for a year. And the third one was her second baby. It happened with her first one too, but she had been breastfeeding for a short time. It's just there was not enough calcium there. So one ended up, the one who was breastfeeding for a year, ended up, can you see with this fracture, this is showing a medical picture, right? This is what a bone density looks like. You can see, I probably don't have to convince you, that if these are nice blocks along the way here, you can see how this got sort of wedged down. It got crushed. And it got crushed, and she didn't do anything, but she was sitting this way because that's the way she breastfed. But she didn't, and that's not bad. I'm not saying you shouldn't breastfeed. I'm not saying you shouldn't sit to breastfeed. I'm just saying make sure that you remember there's no automatic pump there giving that calcium, moving the calcium from your body into the baby. But what happens is that to get that milk out, you've got this great bone bank full of calcium. And guess where the calcium comes from? If it's not coming from your intake of dairy products or wherever else you're going to get your calcium, then it's going to come from your bones. And then you're at risk. Now, this doesn't happen to everybody, but I do think the message is good for everybody. Please breastfeed. It's good for you. It's good for baby. It's good for our population in every way. Make sure you're taking enough calcium to supply that milk with for the baby with adequate calcium. That's the second thing, a little message beyond the whole thing. This is a bone densitometry. So nothing terribly exciting happens. I mean, it's very exciting because we get good data from it. But you lie fully clothed on a nice table. Beside you sits the tech. There's no radiation. She does this all day long. She doesn't wear a big radiation apron or anything like that because there just isn't. There's nothing. So, and it scans your hip. We saw the other one here is looking at the hip. That's one of the areas we look at, and then it plotted on that nice colored graph. And then we also do the whole spine. We do the lower spine for standard ones. We at St. Mike's are very lucky. We have, especially in our unit at 61, we've got a densitometer that actually does our readings for the whole spine from here, from the back of the neck to the top of the sacrum. And that's fabulous because not everybody does that. So then you have to go do x-rays if you don't have our particular approach. It's wonderful because it will give us that picture that we just saw back here of that entire spine, and we can then see whether there's something happening there that we need to be paying attention to. And on these graphs, when you do them several times, they give you a plot for this time, but they'll do the plot for next time too. So you do them every couple of years or whatever the indication is, but you'll see whether you're maintaining your bone density or whether you're losing it. Now, this isn't something you do for entertainment. It's something, but when you have to have it done, it is worthwhile because you can go back and look at the benefits that are right there. So that's a densitometer. Now, what do we do to keep from breaking bones? So I'm jumping one thing to another. Any one of these could be a topic in itself, I know. So I'm going to talk about several things, and we'll move from one to another, and please feel free to ask me any questions you want to. What are some things there's some things we can't do anything with. Let's see what things we can't. You can't do anything with your age, unfortunately, but if you find an answer, let me know right away. Low bone mass, that's something, if you're genetically predisposed to having poor bones, you really have to fight to get those bones not in that category, but you can do it. It's just that you have to work harder. Your race, Asians, are more have more problems than do whites, but whites have the same problem. You have problem with history of fractures. If your mom had osteoporosis, you're more likely to have something like that happen. Diabetic patients have weaker bones. Somehow that sugar in the bones makes them more fragile. And various other conditions, rheumatoid arthritis, any of these conditions where you have to take corticosteroids for it. It's not that you shouldn't do it. Of course, you're going to be treated, but that treatment itself weakens bones. But there are things you can do. You can certainly make sure you avoid excess alcohol. You can make sure you don't smoke. You can make sure you exercise appropriately, get yourself moving, get enough calcium in your diet, get enough vitamin D, and do these things. And if you are on certain drugs that you have to take, then make sure that you're aware of some of these things that you have to look at. And it's important. And estrogen is a big thing that is one of the things that's modifiable. Getting that estrogen in your system, unless it's inappropriate for you, is a good thing to do. Well, so off that big list of 2 whole columns of it, bottom line, make sure you have enough calcium. Where I tell patients you need 1,200 milligrams, 1,500 milligrams oftentimes. There is a wonderful calcium calculator on Osteoporosis Canada. You Google up Osteoporosis Canada and look up the thing that says calcium calculator. And it gives you a diagram of a woman, a diagram of a man, under 50, over 50, and you click on the appropriate, and you get a drop-down menu. And it gives you the things you can take, and tells you how much milk. So somebody says, yeah, I have lots of milk. I have 2 milks in my coffee every day, sometimes 3. I said, yeah, but that's not quite the amount of milk we need. Enjoy your coffee, but have some milk. So that you can find out how much it is. So a glass of milk's got about 370, 350 milligrams of calcium. So you have to, if you're not going to do milk, that's fine, but you've got to do something to get that. Protein, don't forget protein. We sometimes got ourselves so thinking about calcium, which is very important. But we need also protein. And there's this term called sarcopenia, or sarcopenic osteoporosis, sarco-osteoporosis. That just says to you, if your muscles aren't good enough to pull on those on those bones, that's one of the exercises that's why swimming is wonderful. It's great for your heart, doesn't do much for your bones, because you're beautifully floating away there. You need the bones to be standing up, having that pull on those bones. That works well. Vitamin D we just need, at least you need 2,000 units. And don't get yourself too carried away with recommendations from the states for many reasons. Well, we'll get political here, but on the other hand, on the point of vitamin D, they tell you have much less. But remember, we're in north. And we don't have the sunshine that's down there in the southern states. So we need more. And we measure it, we know you need about that much. Exercise is important. We talked about that. And then hormones. If you've got a hormone deficiency like Laura had, we really had to get her to the point where she needed a lot of things, needed weight and health, but she also needed some hormones. Those cycles were really important for her to have those. And postmenopausally and perimenopausally, we need to do that too. And then when something happens with bones, you have to rule out other causes. Well, why are you losing bone? If you've got bad bones, or if you break a bone, so Dr. Earl Bogosh, who runs was the one who's so well known for establishing the teaching in all orthopedic centers really around the world, but it started in Toronto and outside Canada, where he actually talks to people. You don't just end up breaking a bone. If you're 20 and you went for a run in the park and you broke your leg, we got to figure out why. I mean, that shouldn't be happening. Are you a Laura? Or what else happened? Or are you somebody else, Jane, who breastfed a little bit too, and we're not getting that calcium in it? We ought to look at the other causes. That's important. And then, of course, we have lots of very good bone-specific medications. Many of these things are things that we at St. Mike's did some of the clinical research on. I can't say that I'm the chief researcher, but certainly was involved in a lot of the research projects that we had on various drugs that we have. So lots of good things that we could do for bones, but you have to start off with the basics. Got to have those first. And of course, while this is for the recommendations for the heart, they sure go for bones as well. Smoking, heart-healthy eating, make sure you're eating properly, regular activity, and watching your weight. All these things are really important. They're important for bones as they are for the heart. And then I think this is from the European Menopause Society, Menopause and Andrology Society, EMAS. And they talk about various activities, the physical activity pyramid. But the message there is everything counts. So if you're out there raking leaves or you're shoveling snow, there's more these days, you're doing exercise. And if you're doing some stuff around the house, that's exercise. And you get out and do your yoga, that's great. You're going to do for your walk. All these things count, and they're all useful. So add all these things. You don't have to have some sort of magic program that you're into, but if you have one, that's great. But on the other hand, just get yourself up and doing. Park your car a little further away, so you have that extra little bit of a block walk. Instead of getting your car to go over and pick up that bottle of milk, whatever you're going to go across the store, just walk that block. Maybe so. It's hard to make us want to do that because we're kind of comfortable folks, but it's things like that are important. Okay, we've talked about bones. We've talked about the importance of muscles. I want to just very quickly talk about a few other things. This is a cartoon about the blood vessels. I want to talk to you about the heart, because one of the first things that came up from any of those of you who might have heard about the Women's Health Initiative, the WHI, we told people that you shouldn't take hormones, it's terrible, stop those hormones, you're killing people, you're giving you all breast cancer, and they have heart disease, and they're going to die. And the exact opposite is true. But the first thing, the heart. So this cartoon is telling you what the inside of a blood vessel is like. It starts off when we're young. We don't have very much plaque. Down here, this yellow stuff is plaque. The older we get, we're older, is eating, it's everything else. But there's more and more of the plaque shows. And then you go on to when you're over 65 or 70, there is plaque. And not only that, there's a bottom of the plaque where it sort of starts to break down a little bit. So this thing irritates the plaque a little bit. So if you got blood rushing past, it might get stuck there and you get a clot. This one is a problem because when this one breaks down, it raises up the edges of the plaque and the plaque itself can rupture. And so that occurs. So why is that important? Because it was back in 2006, which is shortly after the results of the WHI came out, the Professor Clarkson, a wonderful, he called himself the monkey doctor. He had a big monkey colony. He's an incredible individual. Couldn't get him convinced to come here. He said he was too old to make that trip to Toronto. But he was the one that answered the question. He said, look, folks, when we give hormones in these early ages, not only is it good, it's healthy. It actually protects the blood vessel. If you started here, you have protection of this heart through all these vessels all this time. If you start your hormones somewhere here, well, that's okay. This is the time you're having most of these hot flushes. And so this is not a bad time to start hormones. But if you start waiting too long and you're getting to this point where there's already a damaged blood vessel there, because of aging, because of your genetics, because of whatever might be happening, then you're a person who is a little more at risk. And certainly, when you get to be over 65 or 70 to start hormones, we've already said you get protection of the blood vessels here. But when you start it when you're older, it's more dangerous. Now, we don't know because this is a cartoon. We can't take we have various ways of testing the vessels, but we can't sort of take everybody out and say, well, let me see what your vessels are doing right now. You're really good. You're like a 15-year-old, God willing. But on the other hand, and if you're over 65, this is why doctors have sometimes this decision ahead of time. No, you can't take hormones. Can't take hormones because you're too old. And I want to emphasize, this tells you about starting hormones. This does not tell you how long you can take hormones. So as a quick aside, there is now a rule, in spite of the fact that a few years ago it was said take hormones for the shortest period of time possible and then stop them. For heavens, after 5 years, for heaven's sake, don't take them after that. Okay, 10 years maybe, but then for heaven's sake, you're way over the hill then. And says the lady who's now 50 or 55, or maybe she's as old as 59 because she stopped her periods at 49, hardly over the hill and just starting there. So, it's not true. You can take hormones as long as you need to. Certainly for the first 10 years, we don't worry about it, depending on when you start. The big decision is when you started. Okay? And the second thing is you have to do a measure of the pros and cons. If you're benefiting from these hormones, that's great. It's good for you. If you're sleeping well and you're feeling good and your heart is good, your blood pressure is good, you're not a smoker, you're an exercise, everything is perfect, then it's not that the hormones are making you exercise or making your heart healthy. It's just you are getting one extra bonus point for the fact that you've got hormones as well as this good, healthy living. If you're a person who has had difficulty already, if you're a person who has, for example, had a blood clot in your leg because you were, flying in an airplane for too long, you're going to be a little bit more anxious about giving you hormones, or at least we have to decide how, if the decisions are made, how you're going to get the hormones, because that's a whole other question, a whole other discussion about how you take your hormones and how that might affect your the clotability of the blood. But at any rate, so how long you take hormones is not the question. You can take them as long as your benefits outweigh the risks, and that's sort of a calculation every time you see your doctor. And the how short when you should start them, that's a different story. This is breast cancer. That's the other big bugaboo, because WHO said that's it. Because of breast cancer, you've got to stop taking hormones. Don't start them, because otherwise you're going to get breast cancer. The next 3 slides are 3 ways of looking at this, and I really want to tell you. These are my medical slides, but I want you to look at them because this is what I'm trying to teach my residents, teach my students, because many of them have told too that this is not what you want to do. You don't want to take hormones, because don't give them. If you don't give them, you're not in trouble. So these are the various things that increases the risk of breast cancer. A family history, especially of women who have breast cancer under the age of 50 or around the age of 50 or premenopausal, that raises your risk high. If you're a BRCA patient, that raises your risk much higher. I'm going to do a quick aside because I may not get a chance. If you're a BRCA patient and you've had surgery done and your ovaries are out and your breasts are clear, that you're allowed to take hormones. That's a whole different story. So if you're told that you can't, you have to talk to somebody who knows the stories. But what are we talking about? So family history, if you're overweight, if you're obese, family history, only 1 member is not quite as bad as 2 members. If you start your periods too really early, you start menstruating at age 10. If you menstruate till you're 60, that's not so good, because you're giving the body all this estrogen for a long time, which is good, but we're talking about risk for breast cancer. Here's hormone therapy for 5 years, and that's not made much of a difference. Smoking's not good. Alcohol's a problem. Stop your periods early if you have osteoporosis. Well, I shouldn't be promoting osteoporosis, but osteoporosis means your estrogen is probably low, and so as a result, probably your likelihood of getting breast cancer is lower. This is another way of looking at it. Estrogen for more than 5 years. Look at these are the risks down the list. BRCA mutation, 200 times. It's not just hormones. And finally, I want you to think about this one. This says, how many extra cancers would you have if you were on hormones? So this says, this is the attributable risk. So the baseline risk of women between age 50 and 70, you expect a baseline, if nobody's taken any hormones, that they have about 45 out of 1,000 are likely to get breast cancer. So if you take nothing, you of course don't have any extra ones. If you take hormones for 5 years, 2 extra for 10 years, 6 extra if you take it for 10 years, 15, 12 extra. But a late menopause, so if you have periods till 59 or 61, then that's already more of a risk. If your weight is 10 kilos above where it should be, 14. Alcohol excess, 27. A lack of exercise, 27. So this isn't a message that says, go and take hormones. It's all good for you. It says to you, don't set your sights about avoiding breast cancer by just sitting there and worrying about it. Make sure you exercise, avoid excess alcohol, keep your weight within the normal range. That you can actually do something about. That will keep you from increasing the risk that much. And if you need hormones, take hormones. Okay, there are some reasons people shouldn't take. If you've got bleeding you don't know about, if you've got liver disease, you shouldn't take it. If you've had any estrogen-sensitive breast cancer, for example, those are contraindications. If you've had coronary artery disease, your cardiologist is going to have to decide whether you can take them or not. Stroke, MI, or a blood clot in your leg, shouldn't. And of course, if there's a particular high risk in your family of inherited disorders, you've got to look at these very carefully. So these are contraindications, at least they're contraindications to sort of say, yeah, everybody take it. It's okay, go home and get your package of pills. And just a quick thought about brain. This is an area of really hot research now. Because the brain has lots of areas where estrogen really works. Many things that we could just talk. Any one of these would have an hour's discussion on its own. Cognition. some of the very early studies that were done showing that memory and cognition are improved in women who have hormones. But I think I can't go out and get any more hormones. It's not going to make me any smarter, unfortunately, now. But there is a narrow time when they could see, and Barbara Sherwood at McGill, 25 years ago, showed that if in patients who took hormones, they had their ovaries taken out, and they did a test of their memory before, and their ability to do certain cognitive tests. And some of them, half of them, agreed to take hormones afterwards. Well, they didn't know what they were getting. They just they agreed to go into the study. They got a pill, and half of those got the real pill, and some of those got non-hormones. And they tested them again 3 months later, and the women who took hormones actually performed better. More importantly, they performed as well as they had before they lost their estrogen, and the women who did not have hormones did not perform as well. But when they gave the hormones back to those, because this was a study over a period of about 6 months, they could get it reversed. So what does that say to you? It says to you that when in the very early years, so when you lose those hormones at that time, that works. Estrogen does help cognition. But where is that? We talk about the critical therapeutic window. We know what that is for the heart. For the bones, there isn't a critical therapeutic. You can use them all the time. Older ladies can get bones, except for maybe when there may be reasons why women wouldn't be getting them when they're older to build bone. But you can build bone in somebody who's 75 by giving them hormones. That just may not be the choice therapy at that. It might, but it might not be. But for brain, we haven't got that figured out, and it's really, really important. We know that hot flushes are very important. We know that the reason with the hot flush area there is not only does it interfere with cognition, there changes occur in the brain, and they also affect your sleep. And if you don't sleep, your memory's lousy, and you can't think the next day. Those studies are done. We just don't know quite how to fit that all in together. Like which hormone should you take when, for how many days, at what point, but the area of work that's being done is incredible. So I think that's something to really keep your eye on, because it's something we should learn about generally. And in talking about the brain, I promise this is my one real medical side, same thing as I show my students. We know that a lack of hormones, if once you've had hormones in your system and your system has been sensitized to having hormones, when you are short of hormones, end up with hot flushes. And some people have suffered terribly, and some people don't. Some people just have, my mother had, I think my mother went through menopause. Others came in, can't bear the thought of having men. My mother suffered for decades. And some women do, they really do. But I keep telling them, lucky you're not your mother. On the other hand, here's the story. We've now got something else coming in. So it's not to say that I'm against hormones. I'm really for hormones. But having said that, this is a diagram that tells you how the system works. So if we had a brain, we draw the brain up here. In the brain, there is a pulse generating. It's a machine that goes off every so often. It generates the pulses that go down from here to through another part of the hypothalamus into the pituitary gland, and then you go from the pituitary, where I know I'm already running over time, but I'm almost done. Down to the pituitary, and from the pituitary to the ovaries, and the ovaries respond by getting those eggs growing, and the eggs in growing produce estrogen, and the estrogen gives us what we have, and as little girls, we become big girls, and we become lovely women, and then when we get to the point, so we go through normal cycles, and what happens when you've got enough of those hormones being produced, then you get a feedback back, the body is brilliant, goes back and says, and there's this thing they now call a candy neuron, because there are the various 3 kinds of neurons there, now shortened as candy. So they go up there and they tell the candy neuron, they say, you know what, don't push it anymore. We've got those eggs growing, everything's fine. But then you have a period and the hormones drop and the whole thing starts all over again. So this cycle goes on. But guess what happens? Menopause comes. And it doesn't matter how many messages you get sent down there. You get those hormones going, get this eggs growing. And sometimes you do. So sometimes I have a woman who's 60 comes in with a cyst, and it's an ovulatory cyst because there's been enough banging around at those ovaries, and they managed to find one more follicle that could grow. and you get a cyst. But for most people, it sort of stops. So when you can't get anything happening, you get these crazy messages back, and this whole area, particularly this candy neuron, which is just a little spot, grows. It grows bigger and bigger and bigger and bigger because it keeps sending out more messages. Get those hormones produced. And what happens is not only do they send messages that way, they're useless, but they spill over into a different part of the brain that gives you hot flushes. And that's here, and those are vasomotor symptoms or hot flushes. And of course, what you can do when that happens, you give some hormones, and it gets this thing back in shape. But some people can't take hormones. Some people can't take hormones because they just had a breast cancer, or they've had another cancer, or some other reason why they're not allowed to take hormones. And for them, they have terrible hot flushes, and the younger they are when their ovaries stop working, the tougher it is to go through that. And the good news is that there is now an alternative, and that's not an alternative to hormones generally, but it's treatment for hot flushes, and that's very important. So it's been on the market in the States now for 2 years, and I'm not doing a drug presentation, but it's a hope presentation. This is now passed by Health Canada. It will be on the market. There are 2 different preparations that are coming, and what they do is they leave this stuff aside and keep sending your messages. They come over here to this area where the hot flushes start, and they block that, and they say, nope, no message, block that area, and therefore if you block the messages here, you don't have hot flushes. So those 2, there are 2 preparations that are now passed by Health Canada. Some should be in the market within weeks to months, and if not, the other one should be out within the year too. So for any of those of you who might have had that problem, any of you who know somebody who might, this is true for men also, men who have hot flushes because of their prostate treatments, they may very well benefit from them, although I haven't studied all the studies they've done in men, but we do have this definitely for women. So we're moving ahead, and so not that hormones are good, they're great, but just in case you're not in that category, that's for you. So basically, this is the second last slide. It just says to you, the Women's Health Initiative was wrong. We really had, for all these people who took hormones, they did better. There was a reduction in all these things, in strokes and breast cancer. This is starting them early if you had estrogen load. So there were benefits across the board. They gave the answers wrongly to the New York press, and so the guys who did it, and they were guys, three of the 40 researchers in it, went to the New York Times and presented their data, said, we've got the data, there's breast cancer. Through the whole thing, 20 years back, it's taken us about 25 years to get out of that slump, and we're starting now. So taking hormones, while there is an increased risk, we've already said, you can get because blood clots more readily if you've got estrogen levels there that are higher. There are also a slight increase in breast cancer. But notice in this trial that had estrogen alone, the risks of breast cancer were lower in patients who took estrogen alone. This is a particular estrogen, lower in people who took that particular estrogen than those who took nothing. But that's a whole other story. But I want to tell you that while we talk about bones and muscles, brain is really important. Heart and liver are very important. Liver is a place where it gets metabolized. The ovaries where it comes. I would just as a quick aside say we don't have time to talk about the vagina, but the vagina is extremely important. And local estrogen therapy, even if you take systemic therapy, that may not be enough. You may need some local estrogen therapy, and that you should be able to have, including most women who have contraindication to systemic therapy. That's not true for everybody, but it's for most of them. So the oncologist will help them take it. So this is a quote that I love from Mark Twain. Take what you don't know that gets you into trouble. It's what you know for sure that just ain't so. So hopefully I've convinced you about a few of those things. These are some of the places where you can get information. I've mentioned some of them. So I hope I haven't gone far too long. I said I'd look at my phone, and at the time, and I got so excited about the fact that I thought I had people ask me. So.
Doctor, thank you so much. Why don't you tell us a bit?
My pleasure.
Why don't you tell us a bit, because you teased us, the effects of not having enough estrogen on your vagina?
Oh, that's really important, and it's something to think about at an early stage. Oftentimes when I see patients and I know they're at that age where they're coming through and they're coming to my bone clinic, and I don't have a place there I can do my gynae exams. I mean, there I'm an internist. I say, crossing the gynae office, I wear a speculum on my head. When I cross the street, I tie this bone on my head. And I say to them, but do you notice, is your vagina dry? No. What about sex? Is it painful? Well, we just don't have sex very much anymore. Or maybe do you think we need to give you some local estrogen? Okay, so this can be true. So this is something that is one of the things that you need to think about. Certainly, you should ask your doctors about that. It needs to be prescribed. There are non-hormonal preparations too you can use. Hyaluronic acid is wonderful. The same stuff you put on your skin to have these lovely complexions works very well in the vagina too. But estrogen probably works better. But it's something to make sure ask about. And so vaginal dryness with sex, or just vaginal dryness, sometimes frequent bladder infections start coming. So if too little estrogen down there can predispose you to that. So keep that in mind. It's one of the pictures. It didn't quite hang on the menopause and bone, but I just hung a little bit of vaginal stuff there too. It is.
Can women, because there's a generation of women here who were probably told by their gynecologists that no, HRT, all those New York Times editorials we read 20 years ago, no, HRT. Could they start it now if you haven't started right after when your menopause starts? Can you start HRT anytime? Will it help your bones, build bones?
So that's really a complex question. We talked about vagina.
Yeah.
Yes, those women can take vaginal estrogen, absolutely. And you know what? You do absorb, although you don't absorb much of it, you do absorb some, and women who have very dry vaginas do actually get some absorption even from that. Not enough probably for the bones. If you're a person who is, think of my cartoon of the artery, if you're 65, especially if you've had any of those problems that your doctors might think may represent some kind of heart problems, you need to think very carefully about whether that's a good decision for you. The doctor needs to think carefully. On the other hand, I can't tell anybody how to run their practices, but I will say this. Don't take an absolute no for an answer. Please try and find out why it's contraindicated. Maybe it is. Maybe there you have one of these predispositions for blending blood clots. If you're one of those people that runs in your family, maybe you shouldn't. Or if you're going to go on a preparation, maybe you need something I was asked, and maybe it's going to be asked again. But one of the things that we asked was, how can we minimize our risks for clots? Because the big thing is when you start later would be blood clots. And one of the ways is how you take it. If you take your pills orally, that goes through the liver. We didn't get a chance to talk about livers. We did the diagram for the brain, but didn't do the liver. But the liver is your main metabolic factory. It clears out everything from your bone, from your blood. And when it goes there, you actually get the blood clotting factors also stimulated. So you say, well, isn't it just sensible? Let's not put it through the liver. Right, but anything almost you put in your mouth goes that way. So we have other ways of dosing it and using it as a patch or as a gel or a cream. But I'm going to caution you, again, I'm not here to sell any products. I'm not here to sell anything, but I would like you to know there are really good standard products that are pharmaceutical grade. Be very careful about things that are compounded. We, the Menopause Society in Canada, in the States, and the International Menopause have all agreed we do not have safety data for things that are just compounded. It's not to say we don't sometimes have to go to that for various reasons, but it's not a good way to give it. But if you're going to but you can get estrogen going through your skin that goes directly into the bloodstream then, bypasses the liver, at least for the first pass through. Eventually it's in your body, everything's going through the liver. But it does reduce your risks of getting a blood clot. So it would be another way. So somebody who's older, who might not know, so you're maybe 65 and you've been very healthy and you're a Laura all grown up, who's been healthy all along. Can you take something? And you probably could. Certainly at 60, I don't have much concern. At 65, especially if you're within 10 years, a little bit more of your last menstrual periods, yeah, I think we watch it carefully. Your blood pressure, we have to watch various things. If you're 75 and starting hormones, I'd say, well, I'm telling everybody, since the Queen lived almost 100, the next generation have got to live to 110, 120, so we're going to push those years back a bit. So I think whatever,
Let's see if somebody else has some questions. No questions? Oh, Madame.
I was just asking if you're not experiencing all the menopause symptoms, would you still recommend starting hormone replacement therapy given the marginal increase in risks associated with breast cancer? Are the benefits to brain health, bone density, all of that, they outweigh it?
That's a really good question. That's an important thing to think about. So one of the things that I've been troubled by is one of the things that is so said, well, if you're not having hot flushes, you don't have to take it. Well, I'm not sure that's the only reason. If you look closely at these people, there are lots of things happen. Moods are a problem. Depression around the perimenopause is a real problem. There are problems in terms of your bones are a certain thing to look at. There's certainly local give the vaginal estrogen is virtually benefit for almost everybody. I don't know anybody who would not benefit from some estrogen there. Do you have to take systemic hormones? Well, I think there are so many benefits there that I'd ask, why not? The bones for sure. If your mom had a hip fracture, or she all of a sudden shrunk, and she, it was fun as a kid saying, look, I'm taller than you, I'm as tall as you are, and then all of a sudden you keep being taller than she is because she's getting shorter, then even if she hasn't been diagnosed or wasn't diagnosed with osteoporosis, the likelihood is that's what she's got. So some degree of looking at benefit for bones, and it'd certainly be better to take the hormones, I think, than taking other drugs for bones. I use a lot of drugs. We've got phenomenal bone active drugs, but this has other benefits as well. So I would say, I think everybody should consider hormones. I think everybody should take them. No, do I think you can't survive and be healthy if you don't take hormones? No, I don't think that at all. But what I'm hoping to at least have made you consider is not crossing it off the list just because you got this article or whatever somewhere or other saying you shouldn't take it.
Any other questions? Madam? Right here. The second row.
Thank you very much for all the information. 2 questions. You mentioned brain research and that there's a lot going on with the effects of cognitive decline or whatever related to hormones. Where is it being done? Are we doing it in Canada? Are we doing it at St. Mike's? Where is it? Where do you find the most?
The people who I've worked with most closely are people from the States, from Chicago. Pauline Mackey is an absolutely amazing. She's a psychologist, had a neurophysiologist, and she's won all sorts of awards. She's stunning looking. I'd like to have looked like that. But anyway, and she's brilliant. She's done some really good stuff. Where she did. I'm sure she did. Tell you a quick aside, she brought her as a speaker, and she just brought the house down. I mean, who thought that this woman who came in, stunning, tall, slim, blonde, gorgeous legs. I mean, I see women. I've got a bunch of daughters and granddaughters. I love to see beautiful-looking women. When she arrived, I went to pick her up because she was my invitee, and she said, no, don't bother picking me up. I'll just take a cab. I'll meet you at the hotel. So I sat there and waited. She was an hour late coming, and she said, well, she went through, and here's this lady. She's flying in from Chicago. It was June, or May, I think it was May. And this lovely short skirt, beautifully short, and nice legs to show for it, lovely high heels, and she was only coming from Chicago. She was only going to be there that night. I worked her very hard the next night, but they looked at her and they said, and who are you? She said, I'm Professor Mackey. She told me the story, and oh, are you? And what do you do? And she said, I'm a professor at the University of Chicago, I believe it's Chicago. And why are you here? I'm here to give a lecture. Who's paying you? Well, nobody's paying me. I'm here, and. Could you show us some could you just step aside? They wanted to check her out. They wanted to check her credentials. They had to check her in Chicago. How could a woman looks like that be a professor and have a brain that works like that? And I guess that's probably what they thought when she first got on top of the point. They wouldn't let her go. She talked so well. She is amazing. And she has a bunch of her students who have come along and working that. I mean, she's a person I've followed most closely. There are a lot of Europeans doing. I don't think there's anybody at St. Mike's doing. Now, don't misunderstand me. Yes. People are doing research, and they're doing research on cognition and Alzheimer's. Lots of really good stuff. But in terms of hormones, the effect of hormones is not something that I know anybody who's doing actively here. But I stand to be corrected. So if you know somebody, let me know right away, because I'm going to get in touch with them.
Yeah, and I just have one other question, but it would be quick. When you mention estrogen, is that also estrogen and progesterone? Like I know when they recommend HRT,
Thank you for
it's like
taking
you
that.
do
Now,
both
you
of them.
need, so if you have a uterus, you need progesterone to protect the uterine lining. If for some reason your uterus has been taken out, you don't need you don't need progesterone. And really, estrogen is by far the thing that's really good for us. But you have to have either the protection of the uterine lining. So either you have to take progesterone by mouth, or we now use progesterone IUDs to protect the uterine lining, so it can be there and just take care of that that way too.
We have one last question, though.
Okay, but I'll tell you one other thing. If you, because I've said if you're all okay, the organizers have allowed me. If you have any other questions, feel free to ask me questions. That's going to be your. Feel free if you've got questions, think them up. I'd be happy to answer them later. But the bosses will tell us this. One more.
Madame wants to answer.
Absolutely.
Hi, Christine. There was a lecture that I went to at University of Toronto reunion in the spring. Actually, it was in the fall. It was to be in the spring, but COVID, it was put into the fall. And the lecturer, I went to her lab, and her name was, ironically, Dr. Einstein. That's her name.
Yes.
And she's conducting a study, but I'm not sure that it's menopause and it's the size of the brain.
Yes.
But I don't know. I can't recall whether hormone replacement therapy was part of that study.
I'm trying to remember. She, I actually met her too, and she came to the lecture, and then I had a second speaker who came in addition as well. And yes, she is here. I think. Yes, and she does Jill or something like that. Jill Einstein. Yes, I met her, and she was actually working with with a second speaker I brought a couple of years later, who looked at things in slightly differently, but was a co-study. So there were lots of stuff that's being done. Not to say that, don't misunderstand me. Toronto is an amazing place. We are so lucky to have some of the top researchers right here. But in terms of what I was talking about, these particular receptors, hot flushes and these sort of changes, I don't think so. But that's true. Dr. Einstein, I've actually met her. And she's published some really good stuff. Since I didn't know very much. I mean, I was just invited to come along when she was being visited, and they said, "Oh, you haven't seen your papers? We'll send a few." Okay, please don't send all 100. I won't have time to do them all, but yes, thank you.
Dr. Driscoll said, she'll talk to you at lunch when we move in. Martine has some closing words, and then we'll go into lunch.
Okay, thank you. I'll do that. Oh, I love St. Mike's. They're so organized. They whisper in your ear, and I'm supposed to pretend I didn't hear that. Okay. Well, thank you very much, Dr. Driscoll. That was amazing. As I said, I'm Martine Ehrman. This is all about the Power Circle and bringing in the opportunities to create awareness on women's health inequality. I'm a proud member of the Power Circle. We like to shine exceptional research and clinical care that's led by the people of St. Mike's. We also host events that highlight and demonstrate how philanthropy is making a difference in women's health. To date, we have raised $400,000, and our collective fundraising has supported research to prevent intimate partner violence. It's supported clinical care through My Baby and Me for women coping with addiction and homelessness during pregnancy, the Women's Health Center, and innovative equipment for breast cancer. If you're a guest today and you're interested in joining, we would welcome you. There are people here that would love to talk to you. The annual membership is $2,500, and it gives you exclusive access to events like today, where you connect with St. Mike's clinicians and scientists and hear all about their work. The bigger the Power Circle gets, the more impact we can have on trying to deal with health inequality. With that, we're going to go to lunch. Dr. Driscoll has said she doesn't really want to eat because she's still hot. Having said that, we'll go to lunch and then make it very informal and be able to have a conversation, and she'll really do answer a few questions. So thank you so much for being here.